Welcome to this podcast on the endoscopy of well and poorly differentiated non-pigmented invasive squamous cell carcinoma. Why it is important to differentiate between well and poorly differentiated squamous cell carcinoma is related to the risk of metastasis. While well-differentiated subtypes usually have a low risk for metastasis, poorly or non-differentiated subtypes usually have a high risk for metastasis. Although there are just preliminary data on that, there are some clinical and endoscopic clues that allow us to differentiate between well-differentiated and poorly differentiated squamous cell carcinoma. So let's now look what are the criterion suggestive for well-differentiated squamous cell carcinoma. Usually these tumors show an exophytic growth and present as nodules. Upon dermoscopy, we usually see signs of keratinization, like in this case, these central masses of keratin and then polymorphous vessels that are located over a whitish to yellowish background. Instead, what are the clinical and endoscopic criterion that are more suggestive of a poor differentiated subtype? Usually, poorly differentiated squamous cell carcinoma shows an endophytic growth and therefore presents like an ulcerated plaque. Upon dermoscopy, we don't see signs of keratinization, but we see just polymorphous vessels. So summarizing the dermoscopic criterion in the progression of keratinocyte skin cancer, we learned that actinic keratosis most commonly shows a red pseudonetwork and fine scales, whereas intraepidermal carcinoma is characterized by glomerular vessels and yellow scales. Invasive, well-differentiated squamous cell carcinoma very often shows white circles and masses of keratin, whereas poorly differentiated squamous cell carcinoma usually shows just polymorphous vessels and an endophytic growth.